Anxiety is a generalized sense of apprehension or fear. It's normal and desirable under some conditions, but it can become abnormal when it is excessive or inappropriate. Anxiety may be experienced with a range of physical features, cognitions, and behaviors. Some of the physical features include jumpiness, jitters, increased perspiration and heart rate, shortness of breath, dizziness, nausea. The behavioral features can include the need to escape or avoid a situation, agitation, clinginess, need for reassurances. The cognitive features, these include excessive and prolonged worrying, overly aware of bodily sensations, jumbled thoughts, nagging thoughts. So when we think in terms of anxiety, it's not always bad, but it can be very difficult. Slide 5. Phobias are excessive, irrational fears of specific objects or situations. Now, phobias can involve behavioral component of avoidance of a phobic situation. In addition, it can have physical and cognitive features. Now, cognitive would be the irrational fear. That irrational fear, when that witness of that stimuli creates a physical response, and the behavior then would be the action of avoidance. Anxiety is a general state of apprehension or foreboding. Now, the disorder involving anxiety were historically classified as neuroses, which was originally believed to be organic in nature. Now, the psychodynamic theory posit that the origins of neurosis lay in the psychological factors that neurosis reflected the threat of the conscious emergence of repressed, unacceptable impulses. Now, Freud, he believed that the different kinds of neurosis reflected the different ways in which the ego defended itself against anxiety. Now, this historical based hypothesis united current anxiety, dissociative, and somatoform disorders as neurosis. Now, neurosis has not been used in the DSM since 1980. Instead, they consider observable behavior rather than causation assumptions. The DSM-5 considers dimensions of the disorder: anxiety disorder, panic disorder, specific phobia, social anxiety disorder, and generalized anxiety disorder. Now, as I mentioned in the introduction, anxiety is adaptive and helpful. It's useful when it prompts us to seek medical attention or to study for an upcoming test to avoid a dangerous situation. Now, anxiety becomes maladaptive, unhealthy, and risky when the level of anxiety is out of proportion to the level of threat, or when it occurs out of the blue, not in response to any environmental changes, just out of the blue. When we think in terms of panic disorder, it's characterized by repeated panic attacks, which involve intense physical features, notably cardiovascular symptoms such as a pounding heart, rapid respiration, shortness of breath, heavy perspiration, dizziness, and weakness, which may be accompanied by sheer terror and fears of losing control, losing one's mind, or even dying. Now, panic disorder refers to the recurrent, unexpected panic attacks, criteria A. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or 5 of the list of 13 physical and cognitive symptoms occur. The worries about panic attack or their consequences usually pertain to physical concerns such as worry. The panic attacks reflect the presence of life-threatening illnesses, or social concerns such as embarrassment or fear of being judged negatively by others because of visible panic symptoms, and concerns about mental functioning such as going crazy or losing control, which is criteria B. There is also 2 exclusion criteria for panic disorders. The disorder cannot be due to the use of a substance, example, drugs or medication, or medication condition, and the disorder cannot be better explained by a comorbid disorder. Now, panic disorder is often comorbid with another disorder, namely agoraphobia. About a third to one half of the people with panic disorder have also got or have agoraphobia. The majority of people with agoraphobia have a history of panic attacks. So when we look at panic attack sufferers, often they limit their outside activity in fear of reoccurring attacks, and this could lead to agoraphobia, the fear of venturing out into public spaces. In the DSM-5, agoraphobia is a distinctive disorder involving a fear or a concern, anticipatory anxiety, or excessive worry about being in open spaces, closed spaces, using public transportation, standing in line, being in crowds, and in general, any place outside the home environment. Agoraphobia is diagnosed separately from panic disorder. And if both exist, then two diagnoses are given. About to a half of the people with panic disorder also have agoraphobia, and a majority of people with agoraphobia have a history of panic attacks. Now, if we look at generalized anxiety disorder, it involves persistent anxiety that seems to be free-floating. This type of anxiety disorder characterized by general feelings of dread, foreboding, and heightened states of sympathetic arousal. Formerly, this was referred to as free-floating. Now, phobias are excessive, irrational fears of specific objects or situations. Now, in phobias, they do involve behavioral components, such as avoidance of the phobic situation, but they also include physical and cognitive features. So, where this sort of connects with one another is that you can establish, if you will, an irrational belief or an irrational fear, which could be cognitive or thinking, faulty thinking, and that faulty thinking will trigger, if you will, a physiological response, maybe increased heart rate, anxiety symptoms, which will then trigger an alternative behavioral response, which would be more about the action of leaving an immediate area or escaping. So there's the relationship there of cognitive thinking, physiological, physical, and behavioral, the action. Specific phobias are excessive fears of particular objects or situations such as mice, spiders, tight spaces, or heights. Some of the more, the more common ones are categorized as animal types, which would be spiders, snakes, and dogs. Natural environment types like height, storm, and water. Blood injection injury, seeing blood or receiving an injection. Situational type, in elevators or planes, and then other types. Examples would include phobias of choking or contracting an illness, diseases, or clowns. Now, in most instances of phobia, there are physical features, behavioral features, and cognitive features. The physical features could include jumpiness, jitteriness, increased perspiration and heart rate, shortness of breath, dizziness, and nausea. Now, with the behavioral features could include, and most notably, the escape or to avoid the situation, agitation, clinginess, and the need for reassurance. The cognitive features could include excessive or prolonged worrying, overly aware of bodily sensations, jumbled thoughts, and nagging thoughts. Some social apprehension is normal, perhaps getting nervous for a job interview or a presentation or other public situations. However, the extreme form of this common fear is known as social anxiety disorder. Social anxiety disorder involves an intense fear of being judged negatively by others. It's very common, up to about 15% experience it at some point in their life. But it's important to note when we look at any of these disorders that having some times when we may feel this way is completely different than having it as a diagnosed psychological disorder, which is most notably extreme examples as opposed to some of the everyday type of examples we might experience. And one of the ones that gets often associated that way is this next one. And this is known as obsessive compulsive disorder. It involves the recurrent patterns of obsessions and compulsions, or a combination of the two. Obsessions and compulsive follow a particular cycle. And there are common ones. You'll see them there in the middle graphic. Now, if we look at obsessions, these are intrusive, unwanted, nagging, and persistent thoughts, images, or urges that create anxiety and seem to be beyond the person's ability to control it. Now, on the other hand, compulsions, these are repetitive behaviors or mental acts that the person feels compelled or driven to perform, such as repeated elaborate washing or after using the bathroom. Now, it's really important to note here that this condition is very debilitating. And remember, there are 6 conditions for things to be classified, if you will, as an abnormal behavior. And we'll often use the term, my OCD is kicking in, when we're talking about being particularly organized. However, our meaning in most of our lives don't meet the definition for obsessive compulsive. And it's important to note, when we talk about the myths of mental illness, it's sometimes that part that sort of says it's in my life because I'm particularly neat. That is the myth. That is not obsessive compulsive. This was a slide just to show you some of the examples of thoughts and compulsive behavior. Now, when we look at another form of anxiety disorder, we're looking at adjustment disorders, are among some of the mildest of the psychological disorders. An adjustment disorder is a maladaptive reaction to an identified stressor that develops within a few months of the onset of the stressor. The maladaptive reaction is characterized by significant impairment in social, occupational, academic functioning, or by states of emotional distress that exceed those normally induced by that stressor. The reaction may be resolved if the stressor is removed or the individual learns a more adaptive approach to the stressor in a more successful manner. Now, one of the more newer, if you will, diagnoses is what's known as acute stress disorder. An example of this is PTSD. And here, people will develop stress reactions that follow exposure to traumatic events. Now, this could be combat, it could be a natural event, or it can be a technological disaster. It involves dissociation. This is the feeling of detachment from oneself. You don't feel connected to yourself. An acute stress disorder occurs in the days and weeks following exposure to a traumatic event. Now, more specifically, when we look at post-traumatic stress disorder, PTSD, people develop stress reactions that follow exposure to traumatic events. Now, post-traumatic stress disorder persists for months, even years or decades after the traumatic experience, and may not begin until months or years after the event. The features of traumatic stress reaction: extreme anxiety or dissociations, feeling of detachment from oneself or from one's environment, intrusive memories and flashbacks, heightened arousal and vigilance, and difficulty concentrating. The next slide will just give you a little heads up about an example of someone in contemporary Canadian society who had a rather public, if you will, and understandable experience of post-traumatic stress disorder in Romeo Dallaire. Dallaire is the former head of the doomed United Nations peacekeeping mission in Rwanda, and was discharged from the military for PTSD a few years after the 93-94 mission, in which his forces tried in vain to stop the slaughter of 800,000 to 1 million Tutsis and moderate Hutu. Canadian Force Commander responsible for peacekeeping mission in Rwanda, he witnessed hideous crimes against humanity, in particular genocide. Dallaire suffered from PTSD and in the year 2000, attempted suicide by combining alcohol with antidepressant medication. The near-fatal combination, which left him in a coma for some time. He has since gone on to become a Canadian senator since 2005, and his biography was made into a movie, Shaking Hands with the Devil. And so even though PTSD can be very traumatic and in some kinds fatal in terms of the action people will take, it is also something that can be recoverable. All right, we are done for this particular part of the chapter. We'll carry on in week 4. Good luck, everybody, and keep up the good work. Now remember, everybody, stay focused, do your work, time manage. That's the key to an online success.